Welcome to this CME e-learning series on patient blood management. My name is Jean-François Hardy, and I am the course director for this module. That was made possible through an unrestricted educational grant from V4 Pharma. This is the first of a series of modules on PBM. In this module, specifically, we will define the general principles of patient blood management. The module is composed of presentations on PowerPoint and interviews with experts in the field. Our first presenter is James Isbister. Professor Isbister is a hematologist, and he is now retired, but he was head of hematology and transfusion medicine at the Royal North Shore Hospital. In fact, he is I can say he is the founder of patient blood management. Of course, he didn't invent patient blood management, but he is the one who coined the term patient blood management. And I remember fondly when he presented the concept at NATA's very first meetings several years ago.
I'm James Isbister. I'm a retired clinical haematologist, but remain involved in patient blood management from a teaching, mentoring and research perspectives. I'd like to give you a brief history of the evolution of patient blood management and in particular mention some of my personal experiences over a long career. The evolution of patient blood management really covers 3 centuries. In the 19th century, blood transfusion was not an option, so very much the focus was on patient blood management. During the 20th century, with the evolution of transfusion, it very much became a donor blood product focus, but during the 1980s, when HIV appeared, many questions were being asked about the safety and efficacy of transfusion. And then by the 21st century, we move into patient blood management as we know it today. So in the 19th century, we have medicine becoming scientific, particularly with the development of anaesthesia and antisepsis, which allowed the evolution of modern surgery. I would like to mention one particular person here, and that is Joseph Lister, not only a great surgeon and introduced antisepsis, but he also had a major interest in the blood and wrote major articles on inflammation and blood coagulation. So there was an interest in patient blood management evolving during the time of modern surgery. And at the end of the 20th century, we have Sir William Osler, who I regard as the father of modern medicine because he integrated clinical laboratory services with clinical care and the introduction of major laboratory services into hospitals. And at the turn of the century, of course, we have Karl Landsteiner discovering the ABO blood groups. Before we get on to blood transfusion, in 1899 we do find articles talking about patient blood management, which was not in fact new. Here we have an article, "No surgeon's armamentarium is complete and no surgical hospital perfect in detail without the instruments necessary for thorough blood examination." In Brisbane, at the last Intercolonial Medical Congress before Federation, we have 2 articles presented there. One was on the saving of blood in gynecological operations, and the other was on postpartum hemorrhage, its treatment, anticipatory and actual. And in that article, the author emphasised the importance of treating anaemia during pregnancy by the use of tonics of iron and strychnine. We obviously would not be using the strychnine today. So even in 1899, at that conference, we see what we would now call the 3 pillars of patient blood management: the minimisation of bleeding, pillar 2, pillar 1, the management of preoperative anaemia, and pillar 3, tolerating anaemia because transfusion was not an option. And we have Sir William Osler writing an extensive article in 1899 on the importance of blood examination and the importance of laboratory services in hospitals. When blood groups are discovered, we have the clinician being responsible for both the donor and the recipient. And it was not until the development of the ability to anticoagulate blood and preserve blood that we get the development of centralised blood banking and donor blood management, with the clinician still remaining responsible for the patient. Although we could call that patient blood management, unfortunately the default decision for haemopoietic failure progressively became the use of blood transfusion. And then later in the 20th century, we have the development of the fractionation of blood and what we would now call the very large plasma and blood fractionation sector. During the early part of the 20th century, we see various articles appearing warning about the dangers of blood transfusion. Here we have one pointing out those conditions in which it is little more than a gesture, done as it were to satisfy the urge to do something. We have a British surgeon, Ogilvie, emphasising, "I am unrepentant in condemning the giving of blood during straightforward operations." And William Crosby, "Thoughtless prescription of blood transfusion is playing Russian roulette with bottles of blood instead of a revolver. While the odds are in the physician's favour that nothing will go wrong, the patient takes a risk." Also during the 1970s, we have the development of bloodless surgery, and Denton Cooley, a cardiac surgeon, was prepared to operate on Jehovah's Witness patients. And he felt that not only were these operations possible and safe, but he felt the results on patients were frequently better than those who received extensive blood transfusion. We also have Ron Lapin developing bloodless medicine and surgery in Los Angeles, again for Jehovah's Witnesses, but for other people where transfusion was being minimised. Also in 1970, we have Conrad Messmer and publication of his landmark work on hemodilution, microcirculation, tolerance, anemia, and the concept of the optimum hematocrit. And with Conrad Messmer really emphasised that we must understand the various adaptive mechanisms to anemia. In many ways, Conrad Messmer was talking about the third pillar of patient blood management. Conrad Messmer came to Australia in 1976 and gave a lecture tour around the country, starting in Brisbane, but through all the capital cities. I was in fact indeed fortunate to accompany Conrad Messmer giving a lecture on the hazards of blood transfusion. And this is one of my slides from that time, addressing the major unanswered questions about blood transfusion. And it's interesting, if we look at this slide today, the only one that's really been addressed is post-transfusion hepatitis. We're still questioning blood transfusion in relation to impacts on oxygen transport, immunomodulation, and hemostasis. It's interesting that in 1976, Bloomberg received a Nobel Prize for discovering the Australia antigen and the cause of hepatitis B. And this year, we have the Nobel Prize again being awarded for post-transfusion hepatitis, but in this case hepatitis C, and I'd like to acknowledge Harvey Alter because he was very much involved as a co-worker with Bloomberg in 1976, discovering the cause of hepatitis B. We then move into the 1980s where we have the tragedies of the tainted blood era, and I won't go into this in detail, but it became well recognised that HIV virus could be transmitted by blood transfusion. And we have articles like this appearing, Bloodless Surgery, Now the Gift of Life. In 1988, I published an article in the Medical Journal of Australia entitled A Paradigm Shift in Blood Transfusion. And in that article, I emphasised that in the early days of transfusion, the procedure revolved around the patient's needs, and always should, and emphasised that transfusion therapy should be recipient-oriented and focusing on the patient's problem. So by the end of the 20th century, we're really questioning the risks and benefits of transfusion. Blood transfusion is clearly an important therapy and can be life-saving, but the majority of blood transfusions are prophylactic, that is, they're discretionary, and allogeneic blood transfusion is being increasingly recognised as an independent risk factor for adverse clinical outcomes, and red cell transfusion in hemodynamically stable patients may in fact be causing iatrogenic disease. So it was at the end of the 20th century that Paul Hebert and his colleagues' landmark paper appeared comparing restrictive with liberal transfusions. And the conclusion was that a restrictive strategy of red cell transfusion is at least as effective as and possibly superior to a liberal transfusion strategy in critically ill patients. After 20 years, we still have not advanced from this particular understanding that restrictive transfusion strategies are safe for patients and may in fact be better than liberal. And we have the drivers back to patient blood management. There's the safety driver, the consumer driver, the efficacy driver, and the funding driver. The safety was from HIV. The funding was very much a political one with concerns about the costs and the safety of transfusion. The efficacy driver very much revolved around the indication and in many ways was driven by the lawyers. And the consumer driver started with Jehovah's Witnesses, moved into bloodless surgery and what we would now call patient blood management. What's best for the blood supply? This is really the blood sectors and bureaucracy's challenge. What's best for the patient is the clinician's challenge. There is clearly a tension between these two. So in conclusion, I would like to emphasise that patient blood management is really focusing on blood success, and donor blood management may be required in relation to blood failure and transfusion medicine and blood product management. So that is a brief history of the evolution of patient blood management from my perspective, and thank you for your attention.
Our next guest is Professor Aryeh Shander. He is an anesthesiologist who works at Englewood, New Jersey in the United States of America. One of the founding members and past president of SABM, which is the Society for the Advancement of Blood Management. He has published extensively on patient blood management, and he is an excellent speaker. Hello, Aryeh. I know you've been involved with patient blood management for a long time, but could you present yourself for our listeners?
Absolutely. And by the way, thank you so much for inviting me to this Natal webinar. Jean-François, I am the Emeritus Chief of Anesthesiology, Critical Care, Hyperbaric, and Pain Medicine at Englewood Hospital Medical Center, which is in New Jersey. I also have a clinical professorship of medicine, anesthesiology, and surgery at the Icahn School of Medicine at Mount Sinai. Also clinical professor of anesthesiology and critical care at Rutgers, and that is also in Newark, New Jersey. And last is clinical professor of anesthesiology at the University of Florida in Gainesville.
Thank you. In 2019, you initiated the Global Definition Initiative. Could you tell us more? Why did you initiate the move towards a new definition of patient blood management, and who participated in this initiative?
Well, that's a very good question. And to define this unmet need, I think we need to take a couple of steps back. Despite the fact that we are seeing challenges in implementation of patient blood management, not just in a local sense, but also nationally and globally, surprisingly, what we found is that there are a significant number of patient blood management activities throughout the globe. Whether you go to Southeast Asia, whether you go to even Sub-Saharan Africa, clearly Europe and the Americas, and that although everyone had the same intention in terms of moving from a product-based approach to a patient-centered approach, there were differences in terms of how we define what it is that we do, not just who we are, but what we do. Under those circumstances, we felt that at least if we're going to make this a movement, which we feel it is, we really ought to have a single language where we describe patient blood management. Now, it doesn't mean that by having a definition, we're precluding others from adding what they feel is important in their locale, but at least it contains those elements that we felt were necessary to define patient blood management. So what we did is we got together a few people, you're included, and decided to look to see what elements are needed within the definition. Now, it became cumbersome. The definition could be as long as a full page of print, but we decided that we need to probably divide the definition into two. One, for the public, meaning for the lay person to understand better what this movement is all about, or the concept of patient blood management. And on the other hand, from a practical point of view, we needed to create a definition that would fit healthcare language. So as we define this as an unmet need, to answer the other part of your question, we actually went and connected with as many organizations, which we could list actually later on, that from different countries and different parts of the globe, to again coalesce, if you will, come together and agree upon a definition, or at least the working of a definition. And we did that in two meetings, one on the coattail of the NATA meeting and the other one on the coattail of the Society for the Advancement of Blood Management, or SABM. And we're able to get individuals that represented different patient blood management organizations from all continents at this point represented. In addition to that, we took these definitions to other professional organizations which either deal with patient blood management or transfusion medicine, to see if they would not necessarily endorse it, but participate in this endeavor. And I think we got fairly good responses.
Thank you. Yes, we did get a very good response. Could you now present the new definition of patient blood management?
So if we go to the slide, I think that for everyone to see it, it probably makes more sense. So the overall decision that we had in terms of coming to an acceptable definition had to include the elements which I will read to you and probably pause at each element. And the first one is that patient blood management starts off with the most important message, which is it is patient-centered. It's also comprehensive, global, as well as local or institutional approach to blood hemostasis. And again, hemostasis does not restrict itself to just the stopping of bleeding, but it's a balance between bleeding to death and clotting to death. Again, approach to blood hemostasis implemented to improve patient outcome. It's another element of patient blood management, that all of these activities actually can become meaningless unless we can demonstrate improvement in the quality of life of patients and not just survival. And all this while adhering to the principles of patient safety. So I think that although it may sound like a mouthful, I think that we have been able to capture the main essence of patient blood management. Patient blood management emphasizes patient empowerment and informed choice. Note that we did not use the word consent, which we think is an older term. We feel very strongly that patients have choice. Part of the bioethics, the section on autonomy, the right to bodily self-determination, and therefore we empower patients to not just make the decisions for their healthcare, but walk together with the clinician in an equal, an equal manner, to be able to overlap, if you will, and to align our intents with the patient's intent. Patient blood management involves the timely, multidisciplinary, and interprofessional application of evidence-based medical and surgical concepts, again, designed or aimed at screening for, diagnosing, and appropriately treating anemia, minimizing blood losses throughout the care episode, and supporting the anemic patient while appropriate treatment is initiated. This again states that anemia, again, a global epidemic, is a central issue for patient blood management.
Thank you. What struck me is that a novel element of the definition is that the patient is central to patient blood management. Could you tell us a bit more about this? Why is this important, and how do you make this happen?
Well, if we go back to 2000, where our initial Society for the Advancement of Blood Management meeting occurred, that meeting actually was intended to decide whether there was an unmet need, at least at the time in North America, to address the whole issue of transfusion, which is product-based, versus the clinical aspects of blood use, which again is patient-centered. And again, you were part of that decision-making at the time. And what we identified, that there was an unmet need, that when you talk about transfusion, you're essentially starting off discussing a treatment and not a disease. And I think that you can talk for a whole hour about the treatment, because we do have lectures on transfusions, without ever mentioning what is the underlying disease that we're treating. Now, remember that there's an old quote from medicine from the early 1900s that says that old physicians, when they leave medicine and retirement, have one drug for 20 diseases. And the new physician who enters into medicine at the same time has 20 drugs for one disease. So again, keep in mind that we needed to move away from the therapy itself and look for what is the patient's needs. So making this a long story for a fairly short answer is that all we're looking for is to put this issue of hematological failure, anemia being one, hemostasis being the other, in the context of that particular patient and matching the disease state with the best therapy. And most of the time what we're finding is transfusion, although maybe on the list, it is far down on the list that we could do many other things that will improve the quality of life of the patient, as well as possibly longevity and quality of life, without using transfusion, but using the appropriate intervention, making it patient-centered.
Our next speaker will be Professor Sigismond Lasocki from the University Hospital of Angers in France. He is a professor of anesthesiology. Sigismond has worked extensively on intravenous iron, and he has a project on the dosage of hepcidin. His pet project is called OZET, which in French means Objectif Zéro Transfusion, or the objective, no transfusion.
It is my pleasure to do this course on patient blood management about the first pillar, which is optimizing erythropoiesis. The key messages of this course is that preoperative anemia is very frequent, and that you should test the surgical patients before surgery to find this anemia. That in an hemoglobin below 13 grams per deciliter should be treated, both in men and women. Second, that the two main treatments for anemia are iron, and we will see that we probably should prefer intravenous formulation to obtain the right dose, and erythropoietin, at least for orthopedic surgery. At last, postoperative anemia is also very frequent, and you will see that in postoperative period, decrease in hemoglobin indicates iron deficiency and could be treated. To begin, it is important to know what is a normal hemoglobin level. This is the global population, and you will see that in men, the normal hemoglobin is between 14 and 15 grams per deciliter, and it is between 13 and 14 grams per deciliter in women. In the global population, the prevalence of anemia, as defined by the WHO, with an hemoglobin below 13 in men and 12 in women, represents around 7% of the global population. However, in the patient's population, in the preoperative period, the prevalence of anemia is much higher. It is between 13 and 40%. You have here the prevalence of anemia in the different kind of surgery. And in this meta-analysis of observational study, you'll see that the presence of a preoperative anemia is associated with a twofold increase in perioperative mortality. So anemia is very frequent in pre-op period, and it is associated with an increased mortality. In addition, of course, preoperative anemia is associated with blood transfusion. And you can see here that for women, blood transfusion are much more frequent than for men in surgery, orthopedic surgery, for example, in this observational study of more than 6,500 patients in Austrian centers. That is why we should consider treating an hemoglobin below 13 in women too. Preoperative anemia should be diagnosed with a sufficient amount of time to allow a treatment. Or if you find hemoglobin below 13 gram per deciliter before surgery, we should probably postpone the elective surgery in order to classify and treat anemia for the patients. So in this statement, it is said that an hemoglobin level below 13 gram per deciliter should be treated both in men and women. To treat anemia, we should know the main causes. The first causes worldwide is iron deficiency, and you can see here that the green in these bars indicates the prevalence of iron deficiency among all the causes of anemia, and it represents around 50% in every part of the world. The second cause of anemia is anemia of inflammation. This is the first cause of hospitalized patients. It is sometimes referred as anemia of chronic disease. And in this kind of anemia, the inflammation induces an inhibition of EPO production and of medullary response to erythropoietin. And that is why erythropoietin could be proposed to treat this anemia of inflammation. In the pre-op patients, you can see here in this cohort of around 1,000 patients with an hemoglobin level of less than 13 gram per deciliter preoperatively, that the prevalence of true iron deficiency is around 60% in all kind of surgery. It is a little bit higher in patients with bleeding, such as colorectal cancer patients or gynecological surgery patients. And you also have low iron stores in around 15% of the patients. So iron deficiency is very frequent in pre-op periods, and we have two ways of treating it. First of all, we can use oral iron, or we can use intravenous iron. You can see here in this study exploring the absorption of iron, that whatever the dose of iron you give, the absorption is always limited around 10% of the total dose given. Indeed, if you want to give oral iron for around 1 month, giving 60 milligram per day, you only absorb 175 milligram or less than 150 milligram for 1 month. So if you want to give 1,000 milligram of iron, it would take around 5 to 6 months to give this amount of iron. This is why oral iron is always less efficient than intravenous iron. And you can see here in this meta-analysis that IV iron is always superior to oral iron with regard to the increase of hemoglobin or to the reduction of blood transfusion. So, because we don't have enough time in pre-op period, we should prefer IV iron to oral iron to treat our patients. Indeed, you can see here that in all kinds of surgery, including orthopedic, visceral, gynecologic, visceral or mixed type of surgery, a dose of iron between around 1,000 milligram allow an increase in hemoglobin between 1 and 3 grams per deciliter in the pre-op period. So IV iron is really efficacious to increase hemoglobin in iron deficiency anemia patients in pre-op periods. Then, in absence of iron deficiency or in case of inflammation, it is proposed to use erythropoietin. You have here the two most recent recommendations of the American Society of Anesthesiology and the European Society of Anesthesiology. Both propose erythropoietin with or without iron, but preferably with intravenous iron to treat anemia in pre-op periods. And you can see here that in orthopedic patients, the use of erythropoietin allow a dramatic reduction in transfusion rate in pre-op periods. When you give erythropoietin in pre-op period, it is probably worth to give IV iron together with the erythropoietin. Indeed, in this study, comparing erythropoietin with oral iron to erythropoietin with IV iron, we show an increase in hemoglobin about 1 gram per deciliter in patients treated with IV iron. But most importantly, in that study, we observed that when we give only iron with erythropoietin, we had a very high prevalence of preoperative iron deficiency the day before surgery, with more than 80% of the patients having iron deficiency, whereas when we gave IV iron together with erythropoietin, we had less than 10% of the patients with iron deficiency. So even if you give oral iron with erythropoietin, and if the patient doesn't have iron deficiency in the pre-op period, at the end of the erythropoietin treatment, he will have an iron deficiency because iron is moved from the store to the hemoglobin. So in the last consensus conference on PBM, the Frankfurt one, published in the JAMA 2 years ago, it is stated that clinicians should consider short-acting erythropoietins in addition to iron in hemoglobin in patients with hemoglobin less than 13 grams per deciliter in elective orthopedic surgery. So regarding the postoperative anemia, in preoperative period, you have a certain amount of hemoglobin. Then the surgeons come, and at the end of surgery, you have less hemoglobin. The difference between the two, the bleeding, represents a direct loss of iron. So in the postoperative period, the bleeding, the loss of hemoglobin induces an iron deficiency. So in the postoperative period, you have less hemoglobin. If you look at this study on healthy blood donors who gave only 500 milliliters of blood, which represents moderate bleeding in surgery patients, it takes around between 80 and 116 days for the patients to recover their initial hemoglobin levels. When they received oral iron, they recovered their hemoglobin level in around 1 month, but none of those patients had a normal ferritin level at the end of the 6 months treatment. So it is probably very important to compensate the postoperative bleeding with iron. Indeed, another international consensus statement deal with this question. And the first point is that in case of important bleeding during surgery, you must check for postoperative anemia. Then if the patient have a severe anemia, which is an hemoglobin below 80 grams per liter, in case of symptoms, one should consider the red blood cell transfusion. In absence of symptoms, the postoperative anemia represents a direct loss of iron, and one should consider IV iron treatments. How could we diagnose iron deficiency in this postoperative period? It is important to remember that surgery induces inflammation. As you can see here, major surgery induces a wide increase in CRP, and you have also an increase in serum ferritin, which is directly linked to the inflammation. Those patients also have a decrease in transferrin saturation, which is also linked to the inflammation. So in the postoperative period, patients have higher ferritin, lower transferrin saturation, and you can't use those biological markers to diagnose iron deficiency. Indeed, in the consensus statement, it is stated that high blood losses during surgery may also indicate the need for iron replacement in anemic patients. So only a low hemoglobin level could be sufficient to indicate iron treatment. In this randomized control study of postoperative IV iron administrations, patients were included in postoperative day 1 after orthopedic, general, urology, or gynecology surgery. They were included if they had an hemoglobin level between 7 and 12 grams per deciliter, and if they had a ferritin below 100 micrograms per liter or a transferrin saturation below 20%. They received either 1 gram of ferric carboxymaltose or standard of care. But when you look at these patients, you can see here that at inclusion, they all had a low transferrin saturation and a high ferritin level, indicating inflammation, as we just said. So, in fact, patients' iron deficiency was mainly diagnosed with a low hemoglobin rather than with a low transferrin saturation or low ferritin. Those patients who were treated had higher hemoglobin at 4 weeks than patients with standard of care. But most importantly, patients who received IV iron had less transfusion, less postoperative infection, and lower length of stay after surgery. And also, they had less physical fatigue at 4 and 12 weeks postoperatively. So IV iron in the postoperative period is efficient to increase hemoglobin, but also to improve outcomes of the patients. The last question could be, is it worth to give IV iron to prevent postoperative anemia? This was the question of the very recent PREVENT study, which is a randomized control trial, including almost 500 anemic patients scheduled for major surgery to receive either IV iron, 1,000 milligrams, or placebo. So the study was negative regarding its primary endpoints, which was blood transfusion with no difference between the two groups. However, the patients who received IV iron preoperatively had higher hemoglobin level at all the time points, and most importantly, they had less readmission to the hospital after surgery. So to give iron preoperatively maybe is useful to reduce the postoperative anemia and to improve postoperative hemoglobin levels. So to conclude, in the preoperative period, it's very important to test patients for anemia and to treat them when hemoglobin is below 13 grams per deciliter in women and men. The two main treatment options are IV iron for iron deficiency anemia and erythropoiesis for anemia of inflammation, or at least for orthopedic surgery. Regarding the intraoperative period, it is important to postpone the non-urgent surgery in order to treat the low hemoglobin level in pre-op periods. And then in post-operative period, the loss of hemoglobin represents a direct loss of iron, and the best treatment for this is probably the IV iron in order to improve outcomes and not only hemoglobin levels or the blood transfusion rates. Thank you for your attention.
The next presentation will be by myself. We're going to talk about minimizing blood loss and bleeding. I am an retired now anesthesiologist, and this is what I know best, how to minimize blood losses and bleeding in the operating room. We will now be discussing the second pillar of patient blood management, minimizing blood loss and bleeding. These are my disclosures. Obviously, this will be a very brief presentation since each of the measures proposed could be the object of a full presentation. We will be discussing the second pillar in the preoperative setting, intraoperative, and postoperative setting. During the preoperative period, we have to identify the bleeding risk, and this can range from low to very high, such as in neurosurgery or cardiac surgery, and we have to manage the bleeding risk with regards to anticoagulants, vitamin K antagonists. Their reversal is possible with vitamin K and prothrombin complex concentrates. However, their use is less frequent nowadays. Direct oral anticoagulants are more difficult to manage because it is difficult to measure their effect, and reversal has to be spontaneous. For example, it is suggested to interrupt rivaroxaban, apixaban, and edoxaban 3 days before surgery. The bigatran, depending on renal function, should be interrupted 4 or 5 days prior to surgery. Antiplatelet agents have very different half-lives, and the last intake should range from 3 to 7 days prior to surgery to allow for a platelet function to recover. If that is not possible, we may have to recur to a platelet function. We want to minimize iatrogenic blood loss by avoiding unnecessary blood tests, and we can use preoperative autologous blood donation. A measure which was extremely popular 20 to 30 years ago has now been largely abandoned because the risk of transfusion error is the same, since the blood bag will go to the blood bank. The patient arrives anemic in the operating room. High percentage of units are discarded, so the measure is not cost effective. However, it may be useful for some rare blood groups, patients with multiple antibodies, and patients who are extremely anxious regarding allogeneic blood transfusion. During the intraoperative period, we have to apply a number of strategies, such as meticulous hemostasis and surgical technique, which goes without saying, but still. The anesthesiologist can also apply a number of blood conservation strategies by avoiding hypertension, positioning the patient to avoid venous congestion, but mainly by maintaining normothermia. In this rat experiment, we can see that the prothrombin time, which is measured at 37 degrees Celsius or at body temperature, will not increase despite the fact that the body temperature is decreased. However, if you measure the prothrombin time at the same temperature that the body is, you will see that it increases considerably, leading to a coagulopathy. However, the good news is that if you rewarm the patient, the coagulopathy will disappear and come back to control. We have some autologous blood options. Obviously, we want to reinfuse preoperative autologous blood if it has been harvested and if it's necessary. We can use normovolemic hemodilution, which has not been shown to be truly effective. since most studies were not blinded randomized controlled trials. Nonetheless, the measure normovolemic hemodilution may be used for Jehovah's Witnesses who may be willing to accept the procedure. Now, the procedure consists of harvesting blood at the beginning of surgery, replacing it with normal saline, and then reinfusing the blood after the hemorrhagic phase of surgery has passed. And we have a very important measure, which is cell salvage. Cell salvage should be considered when blood losses are expected to be over 500 mils. Cell salvage is commonly used in a number of major surgical procedures. Reinfusion should be according to the manufacturer of the equipment guidelines. Now, we have to remember that we are reinfusing red blood cells in saline and that there is no plasma, no platelets, and to the contrary, there can be heparin or ACD, the anticoagulant, in the reinfused red cells. There's no absolute contraindication in cancer surgery, neither in infected or contaminated fields. However, in this case, the cell salvage should be considered on a case-by-case basis, and patient consent should be sought. Finally, a leukodepletion filter should be used whenever cell salvage is being used in those conditions. Still, during the intraoperative period, we can use a number of pharmacological agents to minimize bleeding, especially synthetic antifibrinolytics. There used to be epsilon aminocaproic acid. However, its use has become much less frequent, and in fact, in Canada, it's not available anymore. Tranexamic acid has been shown to be effective in a number of procedures, especially cardiac and orthopedics. It's inexpensive and supposed to be safe. There is a natural antifibrinolytic which exists, a protein which is derived from bovine lung. It has been used extensively in cardiac surgery from the 90s to 2008 until publication of the BART trial. Now, the BART trial has been challenged by a number of health authorities, and Nordic Pharma has reintroduced the drug in Europe exclusively for cardiac surgery. The Nordic Aprotein patient registry data shows its safety and suggests that the drug is efficacious. During the post-operative period, there are also a number of things that we can do. We want to monitor and timely manage post-operative bleeding. We want to rewarm the patient if ever he is hypothermic. Again, we want to maintain normothermia to avoid the coagulopathy associated with hypothermia and excessive bleeding. Autologous blood salvage and reinfusion can be used in cardiac and orthopedic surgery, as mentioned previously. We want, again, to minimize iatrogenic blood losses by avoiding useless blood tests. Sometimes we have to manage hemostasis and anticoagulation, especially in cases of during surgeries where massive bleeding has occurred and may have induced coagulopathy. Then we will want to monitor the coagulation status either by point of care or laboratory tests. It is important to base transfusions on test results according to a pre-specified protocol in order to avoid unnecessary transfusions. We will want to administer protamine for residual heparin in cardiac or vascular surgery, especially, and platelets in those patients who have preoperative antiplatelet drugs that are still active and may be causing excessive bleeding. So, in conclusion, for the second pillar of patient blood management, well, surgeons and anesthesiologists are keenly aware of the need to minimize blood losses and bleeding, and in general, this is what we do best. We have innovative surgical techniques. We use cell salvage. We maintain normothermia. We use different pharmacological interventions, etc. So this we do in and out every day in the operating room. Several of these measures will apply to most cases. However, for urgent surgery, some interventions like stopping direct oral anticoagulants or antiplatelet agents ahead of time may not be possible, and then you have to apply different measures to control bleeding and coagulopathy. Now, it should be kept in mind that a restrictive transfusion threshold for allogeneic red blood cells must always be put in place throughout the surgical procedure and afterwards. The next presentation will be by Professor Jens Meier. Professor Meier is head of the Department of Anesthesiology in Linz, Austria. And Professor Meier has worked extensively on oxygen delivery and oxygen consumption. He is now chairman of the scientific committee of NATA.
Welcome to this NATA webinar, the third pillar of PBM, harnessing and optimizing the physiological reserve of anemia. My name is Jens Meier, and I would like to guide you through this topic within the next 10 minutes. Harnessing and optimizing the physiological reserve of anemia is one of the three pillars of patient blood management. I'm quite sure that all of you have already heard about the three-pillar concept. Patient blood management is a multidisciplinary, multimodal approach in which the harnessing and optimization of physiological anemia tolerance plays an important role. The limits of acute anemia in guidelines are given at hemoglobin values between 7 and 9 grams per deciliters. On the left side you can see the guideline from the European Society of Intensive Care Medicine, and as you can read in this text, there is a lower limit for transfusion, a threshold for transfusion at a hemoglobin concentration of 7 grams per deciliters if the patient is non-bleeding, whereas in the two right guidelines, the European Trauma Guideline and the Massive Bleeding Guideline of the European Society of Anesthesiology, it is recommended that a patient should be transfused if a hemoglobin concentration of 7 to 9 grams per deciliter has been reached in case this patient is bleeding. However, these thresholds are far away of what an organism can compensate, and therefore this limit of anemia is given by guidelines, but is actually not the physiological limit of anemia. The physiological limit of anemia is defined by the oxygen demand of an organism, which under normal resting conditions is about 250 milliliters per minute. In contrast to this, usually much more oxygen is delivered. What you can see here is a typical oxygen delivery for a hemoglobin concentration of 15 grams per deciliters, and under resting conditions you have 1000 milliliters per minute oxygen that are delivered to the tissues. If you now measure oxygen consumption, either by a Swan-Ganz catheter or by a measurement of end expiratory O2 and CO2, you can see that the oxygen consumption perfectly fits to the oxygen demand, since only the oxygen that is really needed can be consumed. During acute anemia, oxygen delivery will decline due to a decline of the hemoglobin concentration. However, as long as oxygen delivery is above the oxygen demand, then oxygen consumption will remain constant. At the critical oxygen delivery, also the critical hematocrit or the critical hemoglobin concentration, oxygen delivery will equal oxygen demand, and since only as much oxygen can be consumed as is delivered, oxygen consumption is in a perfect equilibrium between oxygen demand and oxygen delivery. If the hemoglobin concentration falls below this limit during extreme anemia, you will also see a decline in oxygen consumption, since only the oxygen that is delivered can be consumed, and oxygen demand, of course, will remain above these two limits. As a consequence, there will be an extensive oxygen debt that is accumulating during the time that the oxygen delivery is below the oxygen demand. This can be measured in animal experiments. What you can see here is an animal experiment where pigs have been diluted from their normal hemoglobin concentration to rather low values, and as you can see on the left side, the decline of the hemoglobin concentration is compensated for by different hemodynamic changes until a threshold of a hemoglobin concentration of 3 gram per deciliter. After that, the whole cart house of compensation stumbles, and at the end the experimental animal decompensates and dies. The same holds true for several laboratory values. Until a hemoglobin concentration of 3 gram per deciliters, anemia can be compensated, whereas a lower hemoglobin concentration results in severe tissue hypoxia, and by that in arterial lactate and a decline in the pH and an increase in the potassium. However, it has to be pointed out that this is not the complete picture of anemia tolerance, since all these topics are only true for the whole body, and there might be a difference for several organs. For example, it could be that some of the organs in the body have tissue damage by extreme anemia at an earlier time point than the rest of the body has. And in fact, this could be demonstrated by Lasocki and co-workers in 2013. What you can see here is a p-monidazole staining, where you can see on the y-axis the degree of tissue hypoxia, and at the x-axis 3 different hemoglobin levels. And as you can see for the myocardium and the brain, tissue hypoxia is similar at a hemoglobin level of 10 and 4 gram per deciliters, whereas for the kidneys and the skeletal muscle there's a significant increase from 10 gram per deciliter to 4 gram per deciliter in tissue hypoxia, which means that the limit of acute anemia is seen earlier in the kidneys and in the skeletal muscles than for the brain and for the heart. There are some possibilities how to influence this anemia tolerance. One is the depth of anesthesia. What you can see here is a depiction of a classical experiment from van der Linden and co-workers from 2003, where you can see the critical hemoglobin concentration during Halothane anesthesia, and surprisingly, the deeper the degree of anesthesia is, the higher the critical hemoglobin concentration rises, which means the less low you can go with acute anemia, so anemia tolerance is attenuated by high anesthesia. This does not only hold true for Halothane, but also for ketamine. The more ketamine you give, the less the body is able to compensate for an acute anemia. You can use muscle relaxants. If you use them, then the critical hemoglobin concentration is significantly lower, meaning anemia tolerance increases. You can try to use hypothermia. However, it has not been demonstrated convincingly that hypothermia increases anemia tolerance. You can use inotropes with the aim to decrease oxygen extraction ratio, and as you can see here is after acute normovolemic hemodilution to a low hemoglobin concentration and the application of inotropes, the oxygen extraction ratio goes back to the initial volume, indicating that inotropes are suitable for increasing anemia tolerance. Anemia tolerance is nearly not influenced by the heart rate. Surprisingly, even at a higher heart rate, survival times at the critical hemoglobin concentration remain exactly the same. Beta blockade obviously has nearly no influence of anemia tolerance. The compensatory mechanisms of anemia tolerance are driven not by heart rate, but by the contractility of the myocardium, and as a consequence, beta blockers do not play a major role here. Blood loss plays a major role, Anemia alone can be compensated very well. However, the combination of anemia and an acute blood loss of 30 milliliter per kilogram results in severe lactatemia, which means that anemia and hypovolemia in a combination should be avoided. Different volume substitutes result in different degrees of anemia tolerance, Ringer solution being the worst and modern starch solutions being the best. However, it has to be pointed out that the starches cannot be used anymore, at least in Europe, in several indications. Hyperoxia is very effective in increasing anemia tolerance. What you can see here is that the critical hemoglobin concentration can be lowered to values as low as 1.3 gram per deciliters if the FiO2 is 100%. Summing up, one has to say that anemia tolerance defined by the guidelines is a hemoglobin concentration of 7 gram per deciliter for the non-bleeding patient and 7 to 9 gram per deciliter for bleeding patients. These values might differ for patients with comorbidities. If you define anemia tolerance by the organism, the values are much lower than what is stated in the guidelines. There might be differences in anemia tolerance for different organs. However, anemia tolerance can be influenced by several pharmacological interventions. However, it has to be pointed out that for these interventions, clinical studies are lacking so far, since all of the data that has been published comes from animal studies.
We will now have an interview with Professor Philippe van der Linden from Brussels in Belgium. Philippe is a former chairman of NATA. He is also an expert on PBM, and his past work was on the tolerance of anemia. Hello, Philippe. We've known each other for a long time, and I know you've been involved with oxygen delivery in animals and in humans for a very long time. Could you please present yourself to our listeners?
Hello, Jean-François. Thank you very much for the invitation. So I am Philippe van der Linden. I am consultant in anesthesiology. I am working in 2 university hospitals, one for adults, Bruckmann, and one for children, the Queen Fabiola Hospital. I am a professor in anesthesiology at the Université Libre de Bruxelles. And as you told us, during my PhD, I realized several studies evaluating the oxygen delivery, oxygen uptake relationship in different acute conditions, mainly hemorrhagic shock and isovolemic anemia.
Thank you very much. Philippe, in general terms, how do you think the third pillar of patient blood management applies to clinical practice?
Thank you, Jean-François. To my point of view, the third pillar of the PBM relates essentially and most importantly on the transfusion decision according to the clinical context.
On this first slide, could you describe the factors that will lead the clinician to transfuse or to withhold transfusion?
Yes, I think we have to take into account 3 kinds of factors. The first relates to the patient's physiologic reserve, which include the cardiorespiratory function of the patient, taking into account its underlying pathology and the possible concomitant treatments. The second series include the clinical conditions, and more specifically, the amount of blood losses, the ability for the clinician to maintain normovolemia, which is one of the important factors allowing the maintenance of the cardiac output response. And third, the level of tissue metabolic demand. The third parameters relates to the logistical support, mainly the available monitoring the clinicians could use, the knowledge and the availability of caregivers, and the time to obtain the blood products required. So with these different factors in mind, the clinician will decide to transfuse or not a patient, taking into account a range of hemoglobin. We all agree that for hemoglobin above 10 grams per deciliter, most of the patient will not be transfused, while for those with a hemoglobin concentration below 7 grams, most of them will be transfused. And between the two, the different factors we described will help the clinicians to take the best decision for the patient in a clinical condition.
Thank you, Philippe. This is very interesting. It reminds me of a case we had in a young lady who had major scoliosis surgery, and she ended up the case with a hemoglobin of approximately 60 grams per liter. The anesthesiologist convinced the surgeon that everything was all right, and the patient was moved to the ward. So she didn't have very tight monitoring. She wasn't in the ICU, and eventually the patient had important or massive upper GI bleeding, and unfortunately she deceased. So it does show that even if you can tolerate very low hemoglobin concentrations, you have to have an adequate setup to monitor and treat these patients in case something goes wrong.
I fully agree with you, Jean-François, and especially as anesthesiologists, we are, in most of the case, we have the adequate monitoring in the operating room. And the situation could be quite different when the patient awake and go back to his room on the ward.
Okay, so on this second slide, could you describe how the clinician should approach the decision to transfuse? How should he proceed?
Based on what we just have discussed, I think the transfusion practice should be individualized for each patient based on a benefit to risk analysis, what has been called by some authors as the transfusion dilemma. And whenever possible, the transfusion must be based on a one-by-one unit policy with a clinical assessment after the transfusion of each unit. This transfusion practice should be integrated in a patient blood management program that will also include the optimization of preoperative red blood cell mass and a strategy aiming at minimized blood losses.
For my last question, I know this is a simplistic question, given all the nuances you have brought to the topic, but is there a minimal hemoglobin level that always justifies a transfusion, even in the young and healthy patient? In other words, how low would you go?
Thank you, Jean-François, for these challenging questions. Of course, we will never have a prospective randomized double-blind trial that will help us to answer the questions. Still, based on studies performed in healthy volunteers by Richard Weizkopf and co-workers, other work published on Jehovah's Witness patients, and finally studies evaluating tolerance of severe anemic children in sub-Saharan countries due to malaria, I think hemoglobin level around 5 grams per deciliter is the value below which I will transfuse all the patients. Of note, 5 grams per deciliter is also the threshold that has been recommended by the recent Canadian guidelines on blood transfusion in the non-hemorrhagic critically ill children or at risk of critical illness.
Thank you very much, Philippe, for this interview. And thank you for participating in our e-learning module. And we'll see each other again soon. Goodbye.
It will be my pleasure. Thank you, Jean-François. Goodbye.
Our next presentation is by Michael Leahy from Perth in Western Australia. Professor Leahy is a hematologist, and he was involved in the implementation of PBM in the entire health system of Western Australia. He has published extensively on the experience of Western Australia, and these are extremely important articles that have been published and show the clinical benefits and the efficacy of PBM.
This is a talk titled Clinical Benefits and Efficacy of Patient Blood Management by Dr. Michael Leahy from Royal Perth Hospital Haematology Department in Western Australia. So what is patient blood management? Patient blood management, as you will have heard from previous talks, is a multimodal, multidisciplinary, patient-centered strategy aimed at improving patients' outcomes in all areas of medicine, with the consequence of minimizing the need for transfusing blood products. The benefits of this are both clinical and economic, and there are many studies that have outlined the benefits for the individual patient and the jurisdiction-wide health service. This slide, taken from a teaching slide set available at Royal Perth Hospital, indicates that each patient is unique and that a successful patient blood management program needs to be tailored to meet the needs of the individual. Successful patient blood management programs are usually based on the concept of the 3 pillars of patient blood management, utilizing a multidisciplinary team approach. As mentioned previously, implementation of PBM is a hospital and jurisdiction-wide process. It requires a proactive approach to the management of anemia, coagulopathy, and systemic illness in patients, especially in the perioperative setting. It also includes non-surgical patients, including general medical, intensive care, and obstetric patients. There is a demonstrated improved outcomes with less morbidity and mortality in all areas of medicine. There is a reduced length of stay and reduced infection rates. Patient blood management is one area of medicine where there are improved outcomes and reduced costs. In this paper from Western Australia, the implementation of a patient blood management program from 2008 to 2014 was associated with a reduced mortality by 28%, infection rates by 21%, and acute myocardial infarction and stroke by 31%. The length of stay was reduced by 15%. Preoperative anemia reduced from 21% to 14%, and pre-transfusion hemoglobins from 79 to 73 grams per litre. Single unit transfusions rose from 33 to 64%. There were major reductions in units of blood products transfused, including a 41% reduction in red blood cells, 47% in fresh frozen plasma, and 27% reduction in platelets. This was associated with a product cost savings of $18.5 million and activity-based cost savings of $80 to $100 million. A main contributor to an efficient patient blood management program is a preoperative clinic. These are useful for diagnosing anemia, allowing time for optimization of patient iron stores prior to surgery, and reducing the risk of transfusion at surgery. For an individual patient, these focus on their health, the causes of anemia, detection of systemic disease, including renal failure, liver dysfunction, coagulopathy, and the identification of medications that may contribute to increased surgical risks, such as aspirin or non-steroidal anti-inflammatory drugs. An example of this preoperative anemia screening occurred locally in Western Australia, where the implementation of a preoperative anemia and suboptimal iron stores screening and management clinic in elective colorectal surgery was associated with a 53% reduction in red cell transfusions at surgery, a reduced length of stay by 16%, and reduced net costs per case by 27%. The value of identifying patients with anemia prior to surgery is demonstrated in this retrospective audit of blood transfusion in comparison with hemoglobin concentration in patients undergoing elective primary and revision lower limb arthroplasty by Evans et al. They found that if the preoperative hemoglobin was 120 grams per litre or more, the transfusion rate was around 7%. If the preoperative hemoglobin was less than 120 grams per litre, the transfusion rate was 47%. The value of intravenous iron postoperatively in major elective surgery is demonstrated in this paper by Calafala, published in Lancet Hematology. 2 groups of patients were considered. One received postoperative iron if they were anemic, and the others received standard of care. In the group treated with intravenous iron, there was greater hemoglobin recovery at 4 weeks, higher iron stores, reduced transfusion rates, and a decreased mean length of stay, and also decreased severe infections. In cardiothoracic surgery, there is an improved survival in patients who avoid transfusion, as seen in the graph at the top right. Patient blood management in cardiac surgery results in improved outcomes by implementing meticulous surgical technique, having a goal-directed coagulation algorithm, restrictive transfusion thresholds. There is a substantial decrease in red cell, fresh frozen plasma, and platelet transfusions. This leads to a shorter length of hospital stay and lower direct costs. Patients with upper gastrointestinal tract bleeding often have poor outcomes. More recently, there has been an interest in the role of patient blood management in managing these patients, specifically comparing liberal transfusion strategies with restrictive strategies. In a paper from the New England Journal of Medicine in 2013, a restrictive strategy was shown to have improved outcomes in patients with acute upper gastrointestinal tract bleeding. In a paper from Western Australia in 2015, 2,228 adults with a median age of presentation of 70 years demonstrated that 4 or more units of red cells were associated with 10 times increased odds of further bleeding in patients with a hemoglobin of 90 or above. The administration of 5 or more units of fresh frozen plasma was associated with increased mortality at 30 days and 1 year. The conclusion from these studies is that restrictive transfusion strategies probably are beneficial in comparison with more liberal strategies, especially at higher hemoglobin levels. Patients with cirrhosis and end-stage liver disease are frequently anemic and coagulopathic. The principles of patient blood management apply in these patients equally as in surgical patients. Patients generally should not be transfused unless bleeding or symptomatic of their anemia. Viscoelastic testing can be the most useful modality for assessing their coagulopathy. In the intensive care unit, patient blood management should play a significant role. Anemia is commonly encountered in the intensive care unit and often continues during the patients stay in ICU and persist beyond discharge. Anemia and transfusion are independent, significant predictors of worse outcomes. Patient blood management provides a multidisciplinary framework for patient-centered decision-making with strategies centered on the management of anemia, optimization of coagulation and hemostasis, and utilization of blood conservation modalities. Patient blood management has an important role to play in the practice of obstetrics. In the graph on the left, the red cell usage at King Edward Memorial Hospital in Western Australia has declined significantly since the advent of a patient blood management program in 2006. The strategies to reduce blood product utilization in obstetric practice include intravenous iron, intravenous tranexamic acid, and point-of-care guided supplementation of coagulation factors. Patients receiving chemotherapy for solid tumours and hematological malignancies are frequently transfused to maintain the hemoglobin above various arbitrary limits, and they also receive platelets to maintain the count, usually above 10 times 10 to the 9 per litre. The aim of this study was to assess the effects of the WA patient blood management program on the use of blood and blood products in malignant hematology. This was a retrospective audit of patients admitted to Western Australian tertiary care hospitals for intensive chemotherapy for hematological malignancies, and they included stem cell transplants. Overall, there was a reduction in the use of red cell and platelet transfusions by 39 and 35% respectively. What was already a restrictive red cell transfusion threshold became more restrictive, falling from 80 grams per litre to 68 grams per litre. The platelet threshold for transfusion fell from 14 per nanolitre to 11 per nanolitre. There was an increased single unit red cell transfusion rate rising from 39% to 67%. Overall, this program was not associated with any harm in terms of bleeding or myocardial infarctions. There were substantial product-related cost savings. Finally, Althoff and colleagues confirmed the benefits of a multimodal patient blood management program based on the three-pillar strategy in a meta-analysis of 17 studies with 235,700 patients, mainly surgical patients who were included. The transfusion rate was reduced by 39%, the hospital length of stay by 55%, the total complication rate by 19%, and the mortality rate by 11%. These figures confirm many other smaller studies. As mentioned in the editorial accompanying the previous article on the meta-analysis, the safety and efficacy of patient blood management has systematically been confirmed. The stage is set for worldwide implementation, and conversely, not implementing patient blood management represents a substandard of care.
We will close this module with an interview with Aryeh Shander. He will be saying a few words on the essential role of patient blood management in these difficult times. Now, at this time, we're living, as you know, the COVID-19 pandemic, and we're having difficult times across the world. Healthcare is having difficult times across the world. Could you explain how PBM interfaces with the hematological needs of patients?
Well, thank you, Jean-François. That is actually one of the call for action that we've had as a group of clinicians coming together from all corners of the world again. We all know, and no matter where you go, whether you read the WHO releases or whether you read the Pan-American ones, they're all releasing, including North America and Europe, they're all releasing, if you will, alerts that blood supply is at an extreme shortage because of the drastic reduction in a donor population. The reason for the reduction in donor population may be multifactorial, but at the end of the day, the problem is that the inventory is down because most people are either afraid to get exposed in the donor centers, or may be sick themselves and may be afraid to expose others to this disease. Now, it is interesting to note that in all disasters that we know of, there is an effect on the inventory. But what is missing when we look at the inventory is the other side of it, which is the user side, the consumption portion. And consumption either remains unchanged or actually also goes down. You can go down multiple disasters in history, including the Japan tsunami, the 9/11, the Boston Marathon, and many others. There is usually sufficient supply, but if the disaster is large and is sustained, the demand for blood, again, goes down. Now, there may be specific demands, such as Chernobyl, but those come later on when there's time to reassess. And it's actually a concern, especially in North America and United States, because the call for donation, which is urging everyone to do as much as they can to increase the inventory, ends up with blood that gets discarded because it's just the use is not there and the blood gets donated. And as we all know, it's a perishable commodity. We need to rethink how we do this. There will be a need for blood. Hopefully when we see the COVID-19 second surge, again, be gone, if you will, and then all surgeries and other procedures resume, there will be a rise for the call for blood. And under those circumstances, we need to train, if you will, the population to donate late rather than to donate early when blood gets discarded. That really doesn't address where patient blood management comes in. But if we are, and there are some countries, South Korea being one, who decided that they will continue with elective surgery, not like some of the other global countries that came together through WHO to reduce or even eliminate elective procedures that require intervention with transfusions. They continue to actually do elective surgery. The importance here is that with patient blood management, although it's not the intent, it is the spin-off of patient blood management, we can reduce the call for blood substantially, anywhere from as high as 60% to as low as 40%. So even if the inventory drops from say 4 days reserve to 1 day reserve, having patient blood management fully implemented in a center that continues to deliver care during the COVID-19 for other conditions, such as elective surgery, we can continue to do that not just with confidence, but safely and deliver the care needed for the patients. So our call, again, for the medical community, which was just published in Anesthesia Analgesia, was to, again, remember that donor is one side of it, but patient blood management can actually help significantly on the user side, reducing the demand in a safe manner. But additionally, what we bring to the table is the patient-centered approach. So any hematological problem the patient may have, which is currently as a default being solved by a temporary therapy, which is a transfusion, we can actually do a lot better for those patients by implementing patient blood management. Lastly, there's a concern that by introducing patient blood management modalities such as the diagnosis and treatment of anemia, that we will delay surgery. We have sufficient data from Canada, from the UK, and from other countries in terms of the time of diagnosis of cardiovascular patients who are scheduled for cardiovascular surgery, as well as patients scheduled for non-cardiovascular surgery, namely oncologic surgery. We have data that shows that the time of diagnosis to the time of surgery can be in not just in weeks, but in months. It's an opportunity to then make the diagnosis of anemia, look at the etiology, and treat it appropriately, bringing that risk down to zero. So I think we can do all that as part of our, again, shouldering the efforts of the medical community while this pandemic is ongoing.
Thank you. Again, I agree entirely, because here in Quebec at the CHUM, we have the delay between the diagnosis and the treatment in most cases is above a month, is more than a month. And it's just a question of changing our mind frame to make sure that we can diagnose those patients and treat them before they get to surgery, and not just diagnose the anemia 2 days prior to surgery, and then you're only, or just, I mean, and not do anything about it because you say, well, it's urgent, this patient has cancer and he has to be operated, which I agree. I mean, if I had cancer, I wanted to be operated as soon as possible. But if the diagnosis can be made of anemia and treated 4 to 6 weeks prior, well, I think that's a very good, that's the best way to go.
And to that statement, the data does not show that delay, if you will, or that time hiatus of 4 to 6 weeks for anemia treatment has any impact on the cancer outcome. And again, I think that many people are concerned that if they wait those couple of weeks, that something's going to happen to the cancer, is going to grow and become even more of an issue than if you just had the surgery down the minute you diagnose the cancer. In fact, we know that that's not the case from data that's being published. And it supports the contention that this is not necessarily a detrimental delay, but it's actually a positive delay, as you just mentioned, because it reduces the number of risks that you have as you go to surgery if anemia is eradicated.
Absolutely. And the other thing you mentioned about coming back to COVID-19, I think it's important because we'll have to live with that for a pretty long time. Apparently, it's not going to go away right now, within 6 months. It's going to take at least a couple of years before we get full control of the problem.
Unfortunately, you are absolutely correct. Our biggest concern right now, although there's very little information, but there's some suspicion, is that like any virus, the SARS-CoV-2 may actually mutate, and there's concern of increased virulence rather than a reduced virulence. All this is while we're waiting for, again, what we think may be the solution, and those in medicine always know that it's not, which is the vaccines. Mm-hmm. Vaccines clearly will help, but again, we just don't know how effective they're going to be.
Thank you very much, Aryeh, for this interview, and we'll talk to you soon.